Specifically, it's the month of colorectal cancer awareness. So we invited Dr. Wasantha Wijeneayke. He is a senior lecturer in the University Hospital KDU, senior lecturer in surgery, and a consultant general and colorectal surgeon. He's the head of the department at the KDU University Surgery Department as well. And he's the founder president of Sri Lankan Association of Colorectal Surgeons. So, without much ado, I would like to invite Dr. Wasantha Wijeneayke to take over and start the session. Please keep your mics mute. Do not switch on your videos. Be mindful about the when you're using the Zoom. Over to you, Dr. Vasantha. Just check whether you can share the screen.
Yeah, thank you for the invitation, uh, and I would like to uh, talk about this topic because the this month, even though we are at the end of the month, this month is the International Colorectal Cancer Awareness Month, and I'll try. Um, I'll try to share the screen.
Are you having trouble sharing?
Yeah, wait. I'll try to do that. Let me
Just give a minute. There's a problem in screen sharing. Just give a minute.
Mm. Good evening, everybody. Sorry for that technical glitch. And I hope you all can see the screen. Can you all see the screen?
Yes. Yes.
Okay, right. So, as you were brought to awareness that this is the month of International Colorectal Cancer uh, Awareness. And when I was asked whether I could do this, I agreed to do uh, in a perspective concentrating this for primary care physicians. And we are not going to look into a lot of things here, but we will be concentrating on 4 key points. At the end of this, I expect every one of you to recognize what we mean by red flags. That is, there are certain symptoms and signs that we would be naming as red flags, and they need to be recognized and identify them to not to miss this cancer. And the idea of doing that is to reduce the delay of diagnosis and starting the treatment. As we progress, I will point you out why we need to do so, because the delay can cause critical uh, worse critical adverse outcomes. And then, even though we are not having a screening program, formal national screening program, we can apply an opportunistic screening strategies to recognize these patients and then to treat them. And I will take you through a referral pathway, so how to do this in the context of in the Sri Lankan context. So, if we all can change the clinical practice, then we can transform your approach to colorectal cancer suspicion and management to improve, to recognize these patients early, and then to improve their survival. So these are the objectives of this talk today. And first of all, I would like to take you through certain fundamentals of it. And the first thing is why colorectal cancer is important. And we will first look at the global burden, and it is the third most common cancer worldwide, and the second leading cause of cancer-related deaths. In 2020, there had been 1.9 million new cases reported worldwide, and at the same time, there had been 900,000 deaths got recorded. So you can see how important this problem is. And it is projected in 2040, 3.2 million reported new cases, and we are anticipating 1.6 million deaths by then. So this is a global problem, and if you look at this data, you would realize that the trend is in the rise. And the Sri Lankan reality is not much different, and that is, colorectal cancer comes in the top 5 cancers, and the incident wise, it is still the third commonest cancer in the country, and the second leading cause of cancer deaths as well. And from 2001, because we looked at 10 years increase, the incident increase, and from 2001 to 2010, there had been an increase of 2.9 new cases to 6.08 new cases per 100,000 of the population. And the calculated annual percentage increase is 8.9%. In 2022, there are 33,243 new cancer cases were reported. And out of that, out of all these reported cancer cases, colorectal cancer were the second highest reported cancer. So in Sri Lanka, the colorectal cancer incidence is rising, and it is rising faster than many of the countries in this region, Southeast Asian region. And primary care physicians are the first line of defense in reversing this trend through early detection and by timely referring these patients for appropriate care pathways. This is the data from 2005 to 2019 in Sri Lanka, and the 15 years data, if we look at it, there had been you can see there is a rising trend in males as well as in females. The incidence among males is 1 in 23 males are getting colorectal cancer. And if you look at the females, it is 1 in 26. So not much of a difference, though, right? That is male to female ratio is 1 to 1.06. And from 2005 to 2019, total reported cases in Sri Lanka were 24,263. And if you look at the rising trend, in males, it is 8.4% every year. And in the females, it is 7.9%. But if we divide this according to the age groups, and internationally, we recognize that we take 50 years of age as the cutoff point. Those who are less than 50 years, we call them the young colorectal cancers. And when we look at this, the rising trend of this cancer in young population or less than 49 years, it is not in keeping with the entire population rising trends, because annual cancer incidence rising trend in males, it is 15.15 compared to less than 49 years age group, when it compared to the entire population of males, that is 8.4%. And this is almost double. And if you look at the females, it is 11.86, and the general population, it is 7.9. So you can appreciate the fact that the young cancer incidence is in the rise. And in males, it is almost double the general population, and in females, it is about 1.5%. So this is 1.5 times than the general population. So this is an important thing that we need to remember. And the stage of diagnosis of the Sri Lankan population is that most of our cancers are diagnosed at stage 3 and stage 4, because uh, stage 1 it is about 13%, stage 2 it is about 28%, stage 3 is 46%, and stage 4 is 12%. And so 58% of our colorectal cancers are diagnosed as advanced disease. This is a critical finding, and this is an important thing to prevent the diagnostic delay in these patients. And if you look at the data from the West or from Europe, and especially if you look at data from uh, the from British data, you would realize that they have a well-established screening program, and their early cancer detection rates are very high. Whereas our context, in Sri Lankan context, we recognize these cancers as advanced disease. And the age distribution in Sri Lankan age distribution, the peak age group is 60 to 64, and the mean age of diagnosis is 58.7 years, and less than 50 years, 17.4 are less than 50 years of age, and patients between 50 to 70 is 70.8. So, and if you look at this graph on your left-hand side, this shows the age distribution of each age group. So, early onset colorectal cancer is in the rising trend, that is less than 50 years, even though we have taken 50 years as the cutoff because this is the international norm. Now we are trying to implement this as 40 years. We are trying to bring it down to 40 years because we see more and more cancers happening in the age group of 50, age group of less than 40, when it comes to young colorectal cancers. And in other words, among the patients who are being diagnosed with colorectal cancer, for every 6 patients, we diagnose 1 patient below 50 years. Therefore, it is important at the primary care physician level to maintain a lower threshold for investigating patients, those who come to you less than 50 or even 50 to 40 to 50 years. If you take those who are having red flag symptoms need to be investigated properly. And early onset colorectal cancer is rising rapidly in Sri Lanka. This is a take-home message for all the primary care physicians. And so what are the challenges and what are the opportunities we have as primary care physicians? And the challenges are, we don't have a national screening program, but we have an opportunistic screening availability. So if you get a patient who comes to you with red flag symptoms and signs that I will be mentioning soon, you can refer them for proper screening. And gold standard of screening is the colonoscopy. And test. However, we have limited colonoscopy access because of resource constraints, because we are not having colonoscopes in every hospital. We are not having enough specialists, those who can carry out colonoscopies on the patients, and our time and the time that we can dedicate for colonoscopy, carrying out colonoscopy is limited. That is not because we are lazy to do that, but we are not having time because of the limited time allocated per consultant to carry out this test. That is because of we are sharing these facilities among a lot of people. And we have limited colonoscopy access. Sorry, we have a late stage presentation, and 58% is diagnosed late, and there is a median delay of 2 months in there is a median delay of 2 months from the patient side, and there is another delay of 2 months from the doctor's side. So there is an issue there.
We can't hear.
Sorry. And can you hear me now?
Yes.
Yeah.
Yes.
And with these challenges, we will look at the opportunities what we have as primary care physicians. And you are the first point of contact. And FIT test, that is fecal immunohistochemistry test to detect blood in stools, is a cost-effective screening tool, and it is freely available in the country. And if you compare this with fecal occult blood test, this is superior, and the price-wise, this is a cost-effective tool. And the important thing is, with this, this will recognize only human blood. So you don't need to do a lot of restrictions that you have to get your patients to do in order to carry out a FOBT. And the other important thing is from the onset of a colorectal cancer for it to grow into an invasive cancer, it takes about 10 to 15 years from a polyp for it to become a cancer. And so therefore there is a huge window of opportunity if we can recognize these patients, and if we can refer these patients for, if we can refer these patients for proper care pathways. And therefore, this early detection can save lives. What I want to emphasize here is, if you look at the development of or transformation of a polyp to a cancer, and the important thing here is that important point here is there is a precancerous stage of this disease, right? So a polyp is a precancerous stage, and if at the colonoscopy, what we are trying to do at the screening colonoscopy is to pick these polyps and then to remove them. By removing these polyps, we can cure this disease. So that is the important thing. That is how we can change the outcome to save these patients. So the critical role in primary care is, it depends on the primary care physicians. In Sri Lanka, only 30% of patients get referred to endoscopy by the first doctor they consult, by their family physicians or their right. Patients see an average. Patients go to an average of 3.4 doctors before they are being diagnosed, right? And so as primary care physicians, you have the power to change this. And if you look at the natural history, the window for prevention is, you can understand, from the normal mucosa, polyp will get developed, and it undergoes a period of dysplasia. And I'm not going into details of genetic details or how it happens, but I'm just going to give you an outline. And from adenoma becoming a carcinoma, so we call it adenoma carcinoma pathway. And in there are so many changes that happens. There is a time that it undergoes dysplasia, and then only it forms a carcinoma. And for this, it takes 10 to 15 years. So this is the time that we can pick up these patients and refer these patients to cure them at the first instance of these patients, to treat them. So, and if you look at the small adenoma will take about 5 to 10 years to become a large adenoma. And then this advanced adenoma will take another 2 to 5 years to become a cancer. Once it becomes a cancer also, it takes 2 to 3 years to give rise to metastasis, right? And the important thing I want to emphasize here is that primary disease, that is the colorectal cancer per se, will never kill a patient, right? And the cancer per se, the primary cancer, will never kill a patient. So it is the metastasis which will kill this patient. So from a primary cancer, for it to give rise to mets, it takes 2 to 3 years. Therefore, when a patient, this is something that you need to emphasize when you when any of your patients get this disease. It is very important to emphasize this to the patient, and because even them because natural trend is they give up everything. Once they are diagnosed with a cancer, they give up their life, they give up their family, they give up everything. And this is the time, as primary care physicians, you can uh, make them aware that they are not going to die because of the primary cancer. And once they are diagnosed with primary cancer, and even then we have about 2 to 3 years to per, to uh, before it gets metastasized to other organs to save these patients. Okay, so so why this matters? And detection and removal of polyps before they become cancers uh, is the level where we can pick them up and treat these patients. And that is where the screening is important. And early detection will cure this disease. That is stage 1 and stage 2 disease. We can cure them by early detection. And polypectomy is a preventive measure. And we can prevent these patients developing cancers by carrying out a simple polypectomy. So the important thing is, if you take the survival of these patients, stage 1 patient, if we treat them properly, there is a chance of 92% for them to survive for next 5 years. But if you take the same patient and if you wait until they become stage 4 disease is where they have given rise to distal mets, and their 5-year survival rate drastically reduced to about 11%. So this is the important point, that you as primary care physicians can help us from to curb this progress. So, and that is why we need to know these time gaps, as well as we need to have an idea about how this is going to develop. And so when you get a patient with this disease, or when patients come to know about this disease, they would come to you and they would ask you why they get this disease. And so then you have to have and when you get a patient, you need to ask about, you need to know what to communicate with these patients. Right? And there are certain risk factors which are non-modifiable, and we have no control over them. That is, one thing is their age. As they grow older, their risk of getting colorectal cancer is high. And if someone has had a family history of colorectal cancer, especially if they have a family history of first degree relative with colorectal cancer, their chance of getting a colorectal cancer is 4 times more than the general public. Okay. And those who have got certain genetic syndromes like Lynch syndrome, familial adenomatous polyposis, and things, are they are guaranteed to get colorectal cancer. So they are risk of developing a colorectal cancer is 100%. But these are patients who need, that is why these patients need very close monitoring. And with the first instance, when we realize that they are going to get a transformation of these polyps, what we do is we remove their entire colon. And sometimes we remove their colon and the rectum. Right? And that way we can prevent them developing an advanced cancer, and we can make them to live a normal life, a full normal life. And if someone has had polyps, or if someone has had colorectal cancer previously, which has been treated satisfactorily, still there are risk of developing a another cancer is high, and therefore they need close monitoring and close follow-up. So these are things, even though non-modifiable, we can influence, right? And modifiable things are the diet, the low fiber, high red or processed meat consumption, and an important thing, as you all must have realized, that every other person that you see during your consultations is either overweight or at the verge of becoming overweight. Right? So those who are having BMI of 30, above 30, are high risk to develop colorectal cancer. And with that, hand in hand, physical inactivity and sedentary lifestyle, which goes, and that is the reason, if you talk to them in detail, you would realize most of their high BMI is because of their physical inactivity and sedentary lifestyle. And this is what you need to emphasize here is lack of exercise, and lack of exercise. And exercise doesn't mean by carrying out their day-to-day work or day-to-day household work is not considered as exercise. Exercise is during the period of exercise, one need to achieve certain, we need to go above certain heart rate, and duration need to be at least 40 minutes. So these things need to be emphasized to the patients. And the lifestyle modifications, smoking and alcohol, both increase the colorectal cancer risk. So you can, if they have especially if they have a family history, or if they have a personal history of previous colorectal cancer, you need to emphasize that they need to uh, stop smoking and consumption of alcohol. And certain medical conditions also have an impact on the colorectal cancer. Type 2 diabetes and the insulin resistance among type 2 diabetics increase the colorectal cancer risk. And under the current circumstances in Sri Lanka, 1 in 5 are diabetic. And therefore you can, if you look at this, and if you look at our entire population, if we take it as 22 million, right, or 24 million rather, and so almost about 4.5 million are running the risk of, are having type 2 diabetes, right? And it is so high. The incidence is so high. And out of that, their risk of developing colorectal cancer is very high. And Inflammatory bowel disease, ulcerative colitis, if if we if someone suffers with ulcerative colitis for more than 20 years, their risk of developing colorectal cancer is almost 100%. Okay. And so these patients need close monitoring and they need regular colonoscopies. And not only ulcerative colitis patients, those who are having Lynch syndrome and familial adenomatous polyposis patients, and especially need annual colonoscopies. And Crohn's disease has a higher risk of developing colorectal cancer, but it is not 100%. Okay. And some patients have undergone radiation for various reasons, especially following pelvic surgeries, that is uh, ovarian cancer, prostate cancer, and things like that, or uterine cancer. And those patients, uh, the incidence of rectal cancer is higher in these patients because of the radiation effect. And inflammatory bowel disease patients need surveillance colonoscopy every 1 to 2 years, but that is after 8 to 10 years of disease, right? So but that is because after 20 years, there, especially with ulcerative colitis, their chance of getting a colorectal cancer is almost 100%. Okay. So these are things that you need to ask from your patients. And you need to, if you are suspecting of a cancer, colorectal cancer, you have to ask from your patient whether any of their family members has had colorectal cancer. And you need to get a detailed description of their dietary habits. And then their smoking and alcohol consumption. And then you have to ask from patients, those who have got ulcerative colitis, or those, if you suspect with their symptoms, if you suspect these patients to suffer from IBD, that you have to ask from these patients, and you need to exclude these conditions. And if any of you have any suspicion of uh, IBD in any of these patients, please refer them to a person who can carry out a complete colonoscopy, right? Because it is very important for someone to get a complete colonoscopy. That is the visualization of the entire colon up to the terminal lining, right? Because some of these patients, especially Crohn's patients, may not have any lesions in the colon, but they would get the Crohn's lesions, the stricture formation and fistula formation and ulcers in the terminal lining. So therefore, it is important to carry out a complete colonoscopy in all these patients. So how would you get these patients, or what are the red flags, symptoms, and signs, right? Rectal bleeding is number one, right? And please don't attribute rectal bleeding to hemorrhoids. And if you talk to 100 people, and those who are having rectal bleeding, either patient or their doctors, those who have seen these patients, have conveniently concluded as them having hemorrhoids. And when we question them about how it was diagnosed, they can't give an answer. they would come out with various excuses saying that their father or mother or their family members had hemorrhoids, therefore I am also prone to get hemorrhoids and this, that, and the other. Or otherwise, they would say that the bleeding is such that I'm having hemorrhoids. Okay. And the worst thing is that they Google these symptoms and then they diagnose themselves as having hemorrhoids. Hmm. So that is one thing. And the change of bowel habits. If anyone comes to you and complain of a persistent change of their bowel habits for more than 3 weeks, and it can be loose stools, it can be constipation, or change in caliber or the color of stools, then you need to be careful. This can be because of a cancer. Most of the time it is not the case, but if you don't refer these patients for colonoscopy, then we will be missing a lot of patients, those who are having colorectal cancer. And iron deficiency anemia is another symptom. Especially in females, don't think and especially in females, those who are in the menstruating age group, don't think it is because of menstruation that they are having iron deficiency anemia, right? And if any of your male patients have got more than 2 grams less than anemia, and in a female, especially if they are postmenopausal, if their anemia is more than 3 grams less than the lower normal, the first investigation what they need is not iron binding capacities or other things, is what they need is a colonoscopy. Right? And that may be the only sign they are having. Right? That is because right-sided colonic cancers will not give rise to a lot of symptoms until they become really advanced. But if you pick them up, right-side colonic cancers have a very good prognosis. And unexplained weight loss is another symptom. If someone has lost more than 5% of weight over more than within less than 6 months, then you have to be careful, because and especially if the weight loss is unintentional, that means if they are not uh, on a diet plan, or they are not doing anything to lose their weight, but still if they are losing weight, then that is a important thing. And if they lose weight within 6 months, then more than 5% of their initial weight, then those patients need to be referred for colonoscopy to exclude the colorectal cancer. And abdominal pain, persistent abdominal discomfort or a crampy pain or bloating can be because of this. And if someone comes to you and they complain of very non-specific things like feeling fatigue, feeling tired, and them feeling sleepy during the day, which can't be explained, then of course you have to get them to undergo a colonoscopy to exclude this condition. So these are things. So rectal bleeding change in bowel habits, iron deficiency anemia, unexplained weight loss, and abdominal pain and persistent fatigue are 6 symptoms that should uh, pay your attention, draw your attention, so you can present them, you can refer them for colonoscopy. And out of this, rectal bleeding, bowel habit change, iron deficiency anemia, and unexplained weight loss is considered as red flag symptoms, right? Abdominal pain and persistent fatigue is not taken as uh, red flag symptoms, but they are important symptoms that can uh, these patients can get. So critical warning is, if someone is more than 40 years of age and if they come to you with rectal bleeding, please refer them for a urgent colonoscopy. And if any of your patients are having iron deficiency anemia, and the first thing you must, and especially if their age is more than 40 years, then the first thing you have to exclude is whether it is because of a GI malignancy. And for that, what we do is we carry out an upper gastrointestinal endoscopy as well as a colonoscopy, because 99% of these cancers take place in the upper GI tract and proximal upper GI tract up to the duodenum, and then most of them happen in the colon and the rectum, which are accessible by these investigations. And anyone who comes to you with a bowel habit change of more than 3 weeks need to undergo investigations. Right? And there are certain common misattributions. That is hemorrhoids, and don't conclude anyone as having hemorrhoids without examining them. And this examination has to be a digital rectal examination and a proctoscopy at least. Then only they can uh, be excluded as having, or they can be confirmed to have hemorrhoids. And one other thing I need to emphasize here, and these patients, while having hemorrhoids also, they can get a colonic or a upper rectal cancer, which can be missed if you don't get them properly investigated. That is one other thing. And newly onset irritable bowel syndrome is another one, because if you put these symptoms into uh, various syndrome categories, and you might come up with the diagnosis of IBS, but while they are having colorectal cancer. So it is important, before you conclude it as irritable bowel syndrome, especially in a person who is more than 40 years of age, they need to have a colonoscopy, right? And don't attribute their symptoms to their diet and to stress or anxiety, this loss of weight and persistent fatigability and the complaint of sleepiness. Don't think they are stressed or they are because they are having anxiety. It may be so, but still, first thing you need to do is to exclude the cancers which can kill them. So after that, of course, you can investigate them further to come to a diagnosis of any of these things. And so the message what I want to give you is any red flag symptom in the appropriate age group, those who are above 40 years, that is, they warrant investigation, further investigation to exclude colorectal cancer. I'm not saying they are having colorectal cancer, but it is important to exclude this malignancy, right? And please don't delay the referral, because as I pointed out, there is a 2 month delay from the doctor's side, and there is another 2 months delay from the patient side, and altogether there is a 4 months delay between the doctor and the patient to start their management, proper management, right? Definitive management. And so it is important uh, and don't treat them symptomatically without excluding a sinister condition. Right? So in Sri Lankan context, even though we are not having a national uh, screening program, uh, those patients, those people, those who, of your population that you are treating, if uh, they can
If they
afford,
can afford.
sorry, if they can afford, or if they can, uh, if they have access to get a colonoscopy done, refer them to have one colonoscopy during, or otherwise carry out a fit test, that is fecal immunohistochemistry test, and if it is suggestive and if it becomes positive, refer these patients for a colonoscopy, right? And if someone is having a family history of colorectal cancer, the first colonoscopy has to happen at the age of 40 years, right? Or otherwise, it has to be 10 years before the youngest affected relative's age. So suppose if one of your patients' mother is diagnosed at the age of 45 having a rectal cancer, at that of these patients, that patient's children need to start screening at the age of 35 years. That is what I want to emphasize here. Okay. And hereditary syndromes, that is Lynch and familial adenomatous polyposis disease patients at the age of puberty, and Lynch patients at the age of 20 to 25 should have their first colonoscopy. Right? And inflammatory bowel disease patients, 8 to 10 years after they are being diagnosed, every year, even though it says every 1 to 2 years, but every year they need to get a colonoscopy on them. And especially if their inflammatory bowel disease condition is not well controlled. Okay. So available screening tests are fecal immunohistochemical test, and this is a non-invasive. That is the first choice, and this is non-invasive, and no dietary restrictions are required if you compare it with fecal occult blood test. And actually, they need to get a annual testing is what is recommended, but if especially in high risk patients, annual testing is recommended. And this is cost effective, and it can be carried out at primary care level. And colonoscopy is the gold standard, and this has to be carried out every 10 years if the first one is normal. Right? If the first one, if there is a polyp, that if we find polyps in these patients, especially if they are not, uh, uh, if they have variable uh, dysplasias, in those patients, we recommend every third year follow-up colonoscopies. Right? And the important thing is polypectomy is diagnostic as well as therapeutic. Once we remove the uh, polyp, they will not get the disease. That is the important thing. And flexible sigmoidoscopy is an alternative to colonoscopy. If especially in those patients, those who are not willing to undergo bowel preparation, and those who are having various difficulties in bowel preparation, flexible sigmoidoscopy is a good tool. And the reason why I say this is that we have looked at the Sri Lankan data, and what we have realized is more than 75 to 80% of the colorectal cancers are happening distal to the splenic flexure of these patients. And 25% of them are in the rectum, and the other 60 to 70%, about 50 to 60% are are beyond splenic flexure, that is in the descending colon and the sigmoid colon. Right. So flexible sigmoidoscopy can pick them up. That is why it is important. But if they are undergoing flexible sigmoidoscopy only, the flexible sigmoidoscopy need to be carried out every 5 years. Right? So the screening algorithm is once you pick them up as having a high risk to get a colorectal cancer, what you can do is you can offer a fit test, and if the fit test is positive, then refer them for a colonoscopy. And this is the screening algorithm. And even though we are not having a national screening program, if all of you can adapt this screening algorithm, we can pick these patients very early, right? And the important thing that you need to remember is that in Sri Lanka, if the doctor does not initiate screening, it will never happen. So you can't expect your patients to own up to undergo the screening. So you are the gatekeeper to early detection. This is an important thing. So fit test, and it detects occult blood. You know, there are two bleeding patterns. One is overt bleeding, what the patients can see, and the other thing is occult bleeding, where the patients can't see what they are passing blood. So it can detect occult blood, and it is non-invasive, and patients do not need any preparation. And whereas for fecal occult blood test, they need to avoid certain foods, and they need to collect samples for consecutive 3 days, and all these preparations are not needed with fit test. And it is highly sensitive, 87% of sensitivity for colorectal cancer, and the threshold hemoglobin what it needs is 10 micrograms per gram of stools. So it has a 87% sensitivity and 84% specificity and negative predictive value is 99%, and cancer miss rate with if fit test is less than 1%. So this is an ideal tool as a preliminary screening tool. So you can select these. How you can adapt this in your practice is you can select the patient those who are more than 45 years and offer this, and especially for these patients, for people those who are symptomatic, right? And patients those who have a higher risk, you can offer it earlier than 45 years. And those who are symptomatic, you can offer it earlier than 45 years. But for general population of your patients, you can offer it at 45 years of age. And patient education is very important. You can have leaflets in your practice for the patients to read while they are waiting to see you, or you can have posters in your practice, and you can give simple instructions as to how to look for danger signs. And then sample collection is easy, where it is a single sample what you need for a fit test. Okay. And the only thing that they need to do is it need to be handed over within 24 hours of collection. If there is a positive result, you can refer these patients urgently for a colonoscopy. And if they are negative, this year, you can offer the same next year for a patient, those who are having symptoms which can be due to cancer. And the important caveats here is 1 in 10 colorectal cancer patients have a negative fit, right? And persistent symptoms need referral regardless of fit. So if the patient, if with a negative fit test also, if the patient's symptoms are persisting, you have to refer these patients for a colonoscopy. It is because the colonoscopy is the gold standard. Right? And remember, fit can't pick up upper GI malignancies. Right? And it is only for colonic and rectal malignancies. And FIT is a primary care tool, and you can use it opportunistically and during your routine consultations, and that is why it becomes a opportunistic screening tool. Right? And then you can refer these patients for colonoscopy. And if a fit becomes positive once, don't try to repeat it until it becomes negative. Or if your patient come to you and request for another test to uh, confirm that it is negative, don't allow them to do that also. You have to refer these patients with a single positive fit test for a screening colonoscopy. And there are certain triggers that you have to refer these patients to. Rectal bleeding is one, right? And iron deficiency anemia is another one. Bowel habit change and weight loss. These are the four symptoms that we took as red flag symptoms. Okay? And when you examine the patient's abdomen, if you palpate a mass, refer these patients. Don't attribute it to hernias or any other things or a previous a surgical scar or anything. Right? And it can be a abdominal or a rectal mass when you do a digital examination. And if any of your patients has got a positive fit test, of course, they need a referral for a colonoscopy. Right? So don't treat any of your patients, please, as hemorrhoids without excluding sinister conditions. And this is the leading cause of diagnostic delay in Sri Lanka. This is a proven thing. And it is important to rule out malignancy, and it is important to investigate these patients appropriately. So red flags in young patients, you should have a lower threshold for that. And that is because the early onset colorectal cancer is high in Sri Lanka, and it is increasing by about 15% every year. And if you are in doubt, please refer these patients. That is important. So there are certain, and initial primary care workup is there are certain things that you can do. Full blood count is one, and it is essential, and a fit test is essential, and digital rectal examination is a must do in these patients. And you need to especially look for rectal masses or any irregularity in the rectal mucosa. And you have to observe whether there is blood in your glove, and whether there is any anal pathology that you can pick up, and that may be a fissure, that may be a fistula, and document them, and please refer these patients. Basic biochemistry is recommended: renal function, liver function, and electrolytes, because if they are diagnosed as having the disease, then it is easy for us to proceed from there. So don't delay the referral waiting for imaging, and don't do extensive blood works, and don't do any trials with your treatment, and don't allow these patients to come for multiple consultations. If red flag signs are present, refer them promptly. That is the baseline. So in Sri Lanka, 30% of patients had no documented digital rectal examination result, the findings. And 30% with normal DRE had palpable tumors at the clinic, right? So it is important for you to perform a DRE and to document it properly. When we get a patient, we will quickly look at how we proceed from there. This is for you to explain to your patients. What we do is we carry out a colonoscopy and we do the biopsy. And if it confirms, as if we diagnose a cancer, and if it comes as positive, then what we do is that we do CECT of the chest, abdomen, and pelvis. That is to look for the spread of this disease. And especially with rectal cancers, we carry out MRI of the pelvis with anorectal protocol to assess the local disease burden. And then we do the CEA tumor marker levels. And CEA, with regard to CEA, I need to mention one thing, one important thing. CEA is not a diagnostic investigation. CEA is to monitor these patients. That is number one, right? But we need a baseline CEA of all these patients, those who become positive with colorectal cancer. And the the other thing what you need to remember is more than 25% of Sri Lankan population has negative CEAs while having advanced disease even, right? So CEA is not a tool to diagnose, but we do on patients, every colorectal patient, invariably we do this to have an idea about their baseline CEA levels. If baseline CEA is high and following the treatment, if it becomes normal, then we use CEA to follow these patients up every 3 monthly initially, and then 6 monthly and yearly as time goes. And at the time CEA start to rise, we carry out regular CEAs, about two of them, and if there is a consecutive increase in the CEA, then what we do is we carry out complete investigation. Uh, we completely investigate these patients to exclude a recurrence or a distal met. Right. And when it then with this information, we do stage this disease. And for that, we look at the tumor, depth of tumor invasion into the bowel wall, and then we look at the nodal stages, the locoregional nodal stage, and the distal nodal, the lymph node stages. And then we look at the distal metastasis. So the importance of distal metastasis is because this is the thing, this is the manifestation of the primary disease that is going to kill these patients. Okay. So why staging matters is that it guides our treatment decisions. Whether we are going to do surgery, whether we are going to first give chemotherapy, or whether we are going to give chemoradiation, or whether we are going to give chemotherapy and chemoradiation, or chemoradiation and chemotherapy before surgery. Everything depends on this, depends on the staging, right? And with staging, we can predict their survival. Right. If you could remember from the previous slide that stage 1, it is 92% 5-year survival, and stage 4, it comes down to 11%. Right. And this staging will guide us to carry out the follow-up of these patients and the surveillance intensity of these patients. So it is important for us to stage these patients. For primary care, the understanding this pathway is important for you to explain this to your patients. And of course, when they come to us, what we have realized is they trust you all than us, because they are coming to us with a very significant problem. But you all have been knowing them for years, and you all have developed a trust with your patients. Therefore, it is very important to understand how the things are going to happen. And when they come to the tertiary care, they have a suspicion about what we are carrying out and whether we are doing the necessary investigations, or whether some of these investigations are unnecessary, because some of these investigations are not freely available in the government sector hospital, and they are costly as well, right? So they always suspect. Therefore, it is important for you to educate these patients, and for that, it is important to understand this pathway. So, this is a very briefly, I will tell you how we are going to manage these patients. And those patients who come to us with early cancers, and surgery is the main mode of treatment. And this is curative, and their 5-year survival is 92%. Right? And stage 3 is uh, the cutoff as to whether we are going to do only surgery and or whether they need chemotherapy or whether they need radiotherapy, and all these things are being decided. And for stage 3 cancers, what we do is we do the surgery first and then we do chemotherapy. And this is for colonic cancers, right? And even for rectal cancers, we manage them separately. And if these patients' lymph nodes are positive, and invariably stage 3 lymph nodes are positive, and their 5-year survival therefore comes down from the 92% to 68%. And stage 2 survival 5-year survival rate is 88%, right? So stage 3 disease need uh, adjuvant chemotherapy, and for rectal cancer they need neoadjuvant chemoradiation as well. So for when it comes to rectal cancer, what we do is we give neoadjuvant therapy. It may be chemoradiation, and then what we do is we do surgery. If we are doing the surgery, it will be a total mesorectal excision. And current trend is some of these patients to get a chemoradiation regime called total neoadjuvant therapy. In total neoadjuvant therapy, what we do is there are two regimes. One is induction chemotherapy. Induction chemotherapy followed by with chemoradiation. That means we give chemotherapy first, that is for 6 months, and then we give 4 weeks of long course chemoradiation. And while we are doing this, we continuously monitor these patients. And in these patients, some of these patients, especially about 40% of these patients, if they can tolerate this, we can cure the disease or we can control the disease completely with this regime alone. And that is what we call total neoadjuvant therapy. There is another regime where we give consolidation chemotherapy. We start the total neoadjuvant therapy with uh, total neoadjuvant therapy with chemoradiation, and then we follow it up with chemotherapy for another 6 months, right? And at every stage, we follow them up and we follow the progress of the disease. And if we realize that they are responding well, then we continue to complete this, and then we monitor these patients, and we call it watch and wait policy, and with organ preservation. So we are not carrying out surgery on these patients, some of these patients. And the international data, we are not having data yet in Sri Lanka, and this is not yet as established as the primary modality of treatment for rectal cancers. But most of the time we try to do it now, and it has been incorporated in uh, some guidelines, uh, and so we most probably we will also adapt it in the near future. And for advanced disease, that is stage 4 disease, uh, the stage 4 means it has spread to the other organs. That is, it has given rise to distal metastasis. So we give them palliative chemotherapy and systemic chemotherapy, and then we carry out symptom control on these patients. And then in advanced centers, what they do is they give target therapy, that is anti-EGFR, anti-VEGF agents, but with all that, their 5-year survival rate is about 11%, right? And this is the 5-year survival by stages. So key message for GPs, early detection means better treatment options, and it improves their survival. Right? And this is a simplified overview, and treatment decisions are made by a group of specialists, including oncologists, surgeon, uh, radiologist, pathologist, all four, we, a team led by the surgeons, and we decide how best each individual patient is treated. So what can you advise your patients, right? You can advise these patients to increase their fiber intake and to reduce their red meat consumption, and to have healthy fats, omega-3 fatty acids, olive oil, nuts and things, and calcium and vitamin D levels. So dairy products and fortified foods and supplements, they all help with prevention. And lifestyle factors, regular exercise, at least 30 minutes of moderate activity daily, maintain healthy weight, that is BMI between less than between 18.5 to 25, right? And to stop smoking and to limit alcohol consumption. Then close management of their diabetes. And in selective patients, those who have got a history of polyps and things, what we do is we give aspirin as a controlled uh, treatment for some selective patients, right? So, and it is what I feel is it is this counseling, of this type of counseling, if you all can do that, I think they have a better trust on you, and so at the primary care level, you all can get them to do this and to for with ideal uh, prevention. So in Sri Lanka, the patient level barriers are for detection. It is awareness is low, and the stigma and embarrassment and fear of diagnosis and the anxiety, cost is a concern, and traditional medicine is another problem, right? And so the median patient delay is 2 months because of these reasons. And healthcare level barriers are the low index of suspicion, misattribution of symptoms, and limited access to colonoscopy, and the referral delays, and as lack of national screening program, and only 30% is, as I mentioned earlier, get referred by the first doctor, and patients go doctor shopping and they see about 3.4 doctors before they come for first investigation. So as you can see here, this is Sri Lankan data. This is not what I have made up, right? And so there is a delay at both patient and doctor level. So as primary care physicians, you can address this issue and to, by referring these patients early, right? I I don't think these we have time for these cases. We will skip these cases for the, yeah. So symptom onset, and from there is a patient delay of 2 months, and the GP visit, first GP visit, from the first GP visit, only 30% of the referrals take place, and the primary care physicians do get their patients down repeatedly for visits before they refer these patients. So therefore, please try to refer them, assess them properly, and refer them as soon as possible, right? So, and the important thing is 58% of these patients present to us as stage 3 or 4 disease. Right? So it is important, as patient education is an important factor, and primary care vigilance is important. Prompt referral is another important thing, and opportunistic screening is an important thing. So in these are the key statistics that you need to remember. There is a 2 months patient delay, 2 months doctor delay, and patients go see 3.4 doctors in average before they come for the definitive treatment, and only 30% of doctors refer these patients following the first visit. So the key role of the primary care physician is to ask about symptoms, take a detailed history, and ask about the family history if you are suspecting anything, and perform a digital rectal examination, and don't attribute bleeding to hemorrhoids, and order a fit test, and refer these patients to proper referral pathway, and offer screening for these patients, those who become eligible, that is at the age of 45 or at 50, offer them a fit test, right? And counsel them on prevention. So remember, if you carry these things out, and you are the gatekeeper as a primary care physician in Sri Lanka. You are critical. Your role is very critical, right? And your vigilance and prompt action will save these patients. So take home messages. I'm going to finish this. Colorectal cancer is a preventable disease, right? And we have 10 to 15 years to pick them up. Screening saves these lives, and most cases present late in Sri Lanka. That is 58% present late. And early referral will improve their survival. So remember, stage 1 disease, if they are referred to us early, we can make them to live 5 years, 92% of the time. And if we take stage 4 disease, when they come to us, only 11% would be surviving at the end of 5 years. And please don't treat bleeding as hemorrhoids, right? And fit test is a primary care tool which can be used as a screening modality. So as you can see here, all these things can be done by primary care physicians. So therefore, it is critical to get this in action. Okay, I hope I didn't overwhelm you with unnecessary things, but if you have any questions, please feel free to ask me now.
Thank you very much for that very detailed presentation. We have few questions because of the interest of time, it's already past, 10:15. So quickly we can ask maybe 2, 3 questions. There's one question, 7-year-old child with a polyp. What is the advice we can give them?
A 7 years old child with a
The
polyp.
polyp, what to do?
Well, how was it diagnosed? That is very important.
Yes, maybe just you can just say something
Sorry?
about, like, no details not given, so maybe to
Right.
get further details and assess.
Yeah, it is important. What is important is it a single polyp, or is this child having more than one polyp? And if there are more than one polyp, and then we need to exclude familial adenomatous polyposis.
Uh,
And then we have to take it up from there.
so there's another question. If colonoscopy is 100% normal, can we exclude CA, or is it necessary to proceed with further investigations?
You know, if colonoscopy is normal, we can safely exclude, provided that colonoscopy study is a complete colonoscopy study. That means it is visualized up to terminal ileum, and then we can safely exclude uh, colorectal cancer. But having said that, if the patient has symptoms, and if it is the colonoscopy has not been done by a trained person, then they warrant a repeat colonoscopy. It's not other investigations, but a repeat colonoscopy by someone who is experienced and trained to do screening colonoscopy.
If a male more than 50 years, blood picture confirms iron deficiency, no fecal local blood, no
Yeah,
bleeding PR, DER,
yeah.
proctoscopy normal, do we still need to refer for colonoscopy?
What is normal?
DRA normal, no bleeding, proctoscopy normal.
Proctoscopy. Still that way. And especially one thing you have to remember, those patients, those who are present, those patients who present with iron deficiency anemia are not having left-sided cancers. And most of them are having right-sided cancers. So therefore, it is a must to have a colonoscopy.
Okay, then. Maybe we'll stop. No, it's almost 10:30. Okay. Thank you very much then. Thank you very much for all the participants for staying late and participating actively with the questions. Please do fill the Google form for the CPD points. We will be closing the Google form within next 10-15 minutes. So make sure you fill it now itself. Okay. Thank you very much. Good night. Probably meet you next month with our next CPD. Good night.